Hemingway died of a fatal suicide with clonazepam and phenobarbital, so posabenzo and barbiturate.
Pay attention.
Well, no, she used too much of them, possibly a handful instead of the normal one or two, and died, and so they considered that a suicide. And thus the X's on the eyes of the smiley face. Yeah, I mean, certainly in withdrawal you can get hallucinations. That's when you start. Well, when you are withdrawing from benzodiazepines or barbiturates, you can get psychosis. You can end up in a mental hospital for a while. So these are the ones. This is looking at lipophilicity versus hydrophilicity. So this is water down here, the H2O, and this is oil up here. And the reason this is important is, like for most drugs, the ones that are more lipophilic cross the blood-brain barrier much more rapidly. They can also be absorbed through the skin, and they often have a two-compartment metabolism model, as opposed to the ones that are easily dissolved in water that have more of a one-compartment metabolism, and we'll get into that. But the half-life is also listed here. So you can see that oil or lipophilicity, hydrophilicity don't necessarily directly correlate with how long the drug lasts in your system or it has an effect in your system. And benzodiazepines and barbiturates can be administered by almost any route, but of course the most common is orally. When it comes to intravenous, there's actually usually only one that's effective, and that's diazepam. And then for intramuscular, there's only a couple that are actually effective, and midazolam and lorazepam. A number of the others, you can give the injection intramuscularly, but you don't know how long it's going to last because it depends on exactly where the shot landed and on the individual you gave the shot to. So as a physician, that's not a good idea.
Not a good idea.
Sublingual administration also avoids the first pass effect and results in more rapid absorption than oral administration, swallowing it. Oh, well, sublingual, yes, you could chew it up as long as you don't swallow it. I wouldn't recommend it because this stuff's horribly bitter. But if you can tolerate that, you could absorb it more quickly. But there are actually some that are made as a preparation to dissolve on the tongue. A little wafer or
Under
a little,
tongue.
It looks kind of like one of those breath. Yeah, like that. It just dissolves on your tongue. Some of them look like a little strip, like those breath strips or whatever, but instead it has a benzodiazepine in it. So this is looking at trazolam and its pharmacokinetics for intravenous, oral, and sublingual administration. The IV, you can see that you get a fairly high concentration and it's rapidly falling. So this is what I would consider the distribution phase. This is where it's binding to, or primarily binding to proteins. This almost straight line is where your elimination is being dominated by metabolism of the extra triazolam in the bloodstream. And this final phase, which is almost a straight line but of a different slope, is where you're eliminating the protein-bound triazolam. So you have a binding phase, then, distribution, binding, metabolism, and then release and metabolism for the fourth period. So the fraction absorbed compared to the IV for sublingual or oral is about 20%, and that's why these curves are much lower. And bioavailability is about 44% and about 53% for sublingual. So first pass accounts for this difference between these two, because the sublingual here is in green or blue, and the oral administration is in yellow. The IV administration is the one here in red or brown. So another accidental overdose with several benzodiazepines and some coke. Don Simpson, producer of Top Gun and Flashdance. He was doctor shopping and he got almost 15,000 pills from 15 different doctors. Only one of those physicians lost their license.
Jeez.
I don't know. To me, that's always a tough call.
15,000 from 15 different doctors.
See, this is prior to that system where you could tell where somebody was getting medication before coming to see you. So most of these doctors had no idea that this guy was going to 15 or 14 other doctors to get medicine. And often these people got smart about filling, so they would go to different pharmacies. So without a system to be able to tell where this particular patient has gone before, the pharmacist wouldn't even know. Because as long as you go to 15 different pharmacies to fill 15 different doctors' prescriptions, without some kind of database that's recording all of that, nobody will be any the wiser except for you. You'll have 15 bottles instead of one. And I would say there's very few doctors, I'm not going to say there's none, because there's always exceptions, but very few doctors that actually ignore the addiction and would write just willy-nilly for whatever you want, however much you want. I think anybody in that situation as a physician is somebody who feels disgruntled by the system to the point where they just don't care anymore, and they're so damn tired of trying to pay their bills by playing by the rules, they're ready to become a drug dealer with a prescription pad. But those are by far the exception. I would say the vast majority of doctors that get involved in this kind of thing have their heart in the right place. They're trying to do the right thing, and the patient is constantly coming to them and complaining, I don't have enough. I keep running out before this prescription, before I'm supposed to be able to renew, and I'm trying all of these other things that you suggested. They're just not working, so I'm unable to sleep because I don't have enough, whatever, Valium, Xanax, whatever it is. So can you please write me some more? And so then as a physician, you have to turn practically either law enforcement or attorney in your head and be like, well,
no,
I think this guy's lying. Where doctors, I can speak for myself anyway, that's not a call you want to have to make as a physician, whether somebody's lying, because your training anyway is to take people at their word. That's part of being empathetic. So when you have to suddenly start taking the law enforcement side of things and being suddenly concerned about, whether somebody's actually telling you the truth, then the system's already broken down. And to say that, doctors are fueling this prescribing frenzy for opiates or opioids, I think would be also incorrect, because there was a tremendous amount of pressure put on the healthcare system to respond to untreated pain, which is still a problem. But you still have the problem that people will lie to the doctor and say that they're in intractable pain when they're not. So then it's up to the physician somehow to figure out, are you telling the truth or not, when there is no painometer. I can't do an objective test on you, no matter how many tests I do, to find out if you're in legitimate pain. Once again, it comes down to a certain extent, what is legitimate? Are you just hypersensitive to what everybody else can actually tolerate just fine, and therefore you need pain treatment? Or are you actually, have a nerve that's been trapped, or, some other traumatic problem? Or is it all in your head, quotes? Well, the problem is, as we've already covered, psychosocial pain activates the same part of your brain. So if we do the functional MRI, which people would say is the gold standard of being able to determine if you're in pain, it wouldn't matter whether you're actually in physical pain or psychosocial pain, the same part of your brain would light up. And I'd still have to write you the prescription, and you'd still be lying because the pain isn't actually physical. No, it feels physical. So you're not lying. God damn. When are we going to come to the truth here? What's wrong with a little bit of pain? Well, my guess would be that it has to do with the problem of more. That people are so focused on that pleasure that any pain that's getting in the way of getting that pleasure suddenly becomes intolerable. And if people were more focused on how are we going to get by with what we have and make sure that everybody else around us is part of the community and has enough too, that all of a sudden the focus would be no longer on me and my pain, and it would be on how's the community doing.
I think if you learn to tolerate some sort of pain, it kind of makes you open the doors to, I don't know, be more empathetic and more sensitive to other people. And
it can, but I think once again, it's one of those things where your experience doesn't necessarily lead down one path. You have some people that experience chronic pain and they become complete blankety blanks.
What does you get your perception of your effect?
Yeah, are you entitled to pain? Are you entitled to a pain-free life? And then all of a sudden you get pain. But I would say that pain can be useful in that it can help to make people more aware of the people around them and how much other people might actually need help. And that pain doesn't have to be physical. It could be, food insecurity, housing insecurity, any number of the pains that come with poverty. And, if you've ever experienced that, I think you become a lot more empathetic to people that fall into that category, and you become a lot less blind to their problems. And in that way, I think that pain can be very useful if you were then to become a person who is in power. If you remember it and you actually value trying to help other people not experience that pain, or at least not experience it as much, I think that could be great. But if you remember that pain and you absolutely deplore it and you think everybody else who's experiencing it is just a whiner and you want to ignore it, you're going to get drunk or high or something, and you're going to, if you have the means, you're going to obliterate the memory of that pain with whatever you can get your hands on. And in that way, that pain could be a horrible thing, Jails, institutions, and death. Anybody? But when it comes to the absorption of benzodiazepines, they're readily absorbed through the lining of the mouth, stomach, or the intestines. The more lipophilic they are, the more rapidly they absorb. The more fat, the more rapidly their onset. And with that comes, if you're going to experience euphoria, that's what usually drives it. That's also part of what makes tobacco so addicting, and anything that you inject IV so addicting, because it hits you really fast and really hard. And when it does that, that change in neurotransmitter levels, specifically dopamine, is what you notice. And if that's also associated with an opioid level change or endogenous opioid level change, you're going to say, I like it. Not only did I notice it with dopamine and I want it, but I also like it. And therefore, you're going to be hooked.
Yeah.
But for all of them, the maximum plasma concentration occurs in about an hour. When it comes to distribution, the ones that are lipid soluble have a faster onset because they can cross the blood-brain barrier more rapidly. They usually have a shorter duration overall. They are partially sequestered in body fat and serum protein, and that leads to this two-phase excretion curve that we were saying, the one slope and then the other slope. All benzodiazepines are widely distributed, and most of them are highly protein-bound. And by highly, up to 95% of it is bound to a protein and not free in the blood. And the difference is the ones that are lipophilic end up in this phase binding to a protein, and thus it looks like elimination, but actually it's being bound. And then in this part, they're being metabolized and also removed from the protein. So the elimination is slower. In the hydrophilic one, it doesn't bind to the protein, so the concentration is a little bit higher, but you also have the single phase of elimination. So you don't have a reservoir of the drug bound to protein. That's what this is talking about. The hydrophilic drug doesn't bind to albumin, which is the predominant protein in your serum. It does have 8 oil-loving binding pockets where a lipophilic drug can bind, and other lipophilic substances in your blood, like hormones and cholesterol, also can bind to these proteins, and that's how they get transported around, because oil droplets don't usually mix with blood. But when you can get the lipophilic substance bound to the protein, then it can travel through the bloodstream, and eventually it will come off of here and diffuse. So the distribution for very large drug molecules is usually confined to circulation because they can't get through the pores in the capillary. For very polar drugs, they can make it through the pores, but they can't make it through the cell membranes of other cells to actually have much effect. The lipophilic drugs are the ones that are ending up in fat cells, as well as in your circulation. And drugs that are hydrophilic end up with a more even distribution, although being perfectly uniform is very uncommon. Because as we mentioned already, you have to either be a weak base or a weak acid to get through the stomach wall, and that's how most 95% of drugs are absorbed anyway. So because these drugs can easily cross the blood-brain barrier, they can also easily cross the maternal and fetal barriers, like the maternal circulation, placental circulation barrier. And the more lipid soluble they are, the more effect they have on the central nervous system of the mother and of the fetus. And they can cause fetal depression as well as respiratory depression. And there is some evidence to believe that benzodiazepines can cause birth defects. And they also can easily enter mother's milk and cause suppression or depression of the neonate.
Jesus.
And benzodiazepines during the third trimester have been shown to increase cleft lip and palate. The fork right here, the lip is actually separated. Fetuses can easily become physically dependent on the benzodiazepines and undergo withdrawal after delivery. And third trimester use has also been associated with problems with the baby being able to regulate its temperature, problems with breathing, problems, of course, with drowsiness, and this muscle weakness, which is also just a complete lack of tone, muscle tone. Muscle tone is what allows people to like sit up or hold their head up or hold your arms up, and it leads to this floppy baby syndrome, which sounds funny, but it sure doesn't look funny. The baby can't hold his or her head up, they can't sit up, they can't move their limbs, basically. So it's just a complete lack of tone, muscle tone. I believe this is something that's temporary, and within a week or two, it goes away, but I don't know the entire pathophysiology of that one. So the difference between short-acting and long-acting benzodiazepines, with intermediates being somewhere in between, is are they inactivated directly by metabolism, or are there active metabolites? And long-acting have active metabolites, short-acting do not. So when a long-acting drug is metabolized, sometimes the intermediates, or if you start with a drug, you metabolize it, you end up with this intermediate. Sometimes that intermediate, before being metabolized finally to something that can be eliminated by the kidney, is actually more active than the original drug was. That's often the case with these long-acting benzodiazepines. And benzodiazepines, at least clinically, are grouped by how long they act. The short-acting ones are often the ones that are used for surgery, like midazolam or triazolam. Some of the intermediates can be added to a long-acting, but during the attempts to control the symptoms of alcohol withdrawal, almost universally, a long-acting benzodiazepine is the foundation of that treatment plan. Intermediates or short-acting can be added to it for symptom control, but usually this is what's used to try and reduce the chances of the person experiencing seizures or DTs. So in this relatively complicated diagram, what I did was put a blue box over the ones that are considered long-acting, and you can see this is the common pathway for almost all benzodiazepines to be eliminated. They're turned into oxazepam, they're conjugated, and they're eliminated in the urine. But most of these long-acting ones, especially this the diazepoxide, has two intermediate active intermediates, and then this active intermediate that actually has a half-life of 30 to 100 hours. So that one's got a really long half-life. And this flurazepam, in and of itself, is completely inactive. It has no effect on sedation or anything like that, but it's metabolized into these two intermediates, one that has a short half-life of 2 to 4 hours, and one that has a very long half-life of 40 to 100 hours. So this is just looking at elimination half-life of benzodiazepines and some of the newer hypnotics down here, the sleep aids, zolpidem, Ambien. And some of these long-acting benzodiazepines have really long elimination half-lives. It's to give you some idea of how different it is to be in the long-acting versus ultra-short-acting groups. Orders of magnitude different. Some of the things that affect the physiologic or affect pharmacokinetics are physiologic. The big one is aging. Another one, of course, is gender. So, well, I won't get into the specifics, but basically, as you get older, the chances of overdosing using a benzodiazepine increase. And so what you used to be able to handle when you were younger is no longer something that you can handle, especially if you're adding something like alcohol. And I think that's a frequent cause of overdose for celebrities. Some other things are obesity level, liver disease, because the liver is doing most of the metabolizing, kidney disease, because the kidney is what's actually filtering the metabolites out and eliminating them, and then ethnicity, because that controls some of the liver enzyme types and how quickly they metabolize things like diazepam and alprazolam. This is more for your benefit. If you know that your client is on one of these drugs, you can look here and you can see what its onset of action is. It intermediate, rapid, or slow? The peak onset in hours, half-life, and then how is it eliminated, and what's the dose equivalent, because there is a significant difference in potency for these different drugs. Same with this. I mean, I'm not expecting you to look at this and go, yep, got it, go ahead and quiz me. I'm not going to test you on this stuff. What I do want you to be able to do is look back and look in this table if you know that your client was abusing diazepam, and then you can know more about what happens when they took diazepam.
Gamma-aminobutyric acid, or GABA, is the primary inhibitory neurotransmitter in the mature brain. It reduces neuronal activity of target cells through its binding to GABA receptors present on the cell surface. Nearly half of all synapses of the brain express some kind of GABA receptor and are thus responsive to GABA. There are at least 3 types of GABA receptors: GABA A, GABA B, and GABA C. GABA A and GABA C are ligand-gated chloride channels. Upon transmitter binding, they open and allow chloride ions to flow into the neuron, making it more negative or hyperpolarized and thus less likely to generate action potentials. GABA B acts through a G protein to activate potassium channels, which allow positively charged potassium to flow out of the cell, again resulting in membrane hyperpolarization and a subsequent decrease in neuron responsiveness.
Wow.
GABA is believed to play a major role in controlling neuronal hyperactivity associated with fear, anxiety, and convulsions. GABA A receptor is composed of 5 protein subunits. In addition to binding sites for GABA, it has allosteric binding sites for other substances, known as GABA modulators. These are molecules that can increase or decrease the action of GABA, but have no effect in the absence of GABA. For example, benzodiazepines, a class of drugs used to treat anxiety, bind to GABA A receptor and facilitate its binding to GABA, thus potentiating GABA inhibitory effect. Other positive modulators include barbiturates, alcohol, and propofol, among others. Examples of negative modulators are convulsants, such as flumazenol. Flumazenol reverses the effects of benzodiazepines by competing with them at the same binding site on GABA A.
Sorry.
Thank you for watching. Please feel free to suggest a topic you want us to cover by leaving a comment below.
In this lecture, we're going to cover the pharmacology of anxiolytic and hypnotic drugs, so let's get right into it. The primary use of anxiolytic and hypnotic drugs is to treat anxiety and insomnia. Anxiety is generally defined as an emotional state characterized by excessive feelings of worry, fear, and nervousness, while insomnia is generally defined as the inability to initiate, maintain, or achieve restful sleep. Now, in order to gain better understanding of how anxiolytic and hypnotic drugs work, first we need to discuss the role of GABA in the central nervous system. So, gamma-aminobutyric acid, or GABA for short, is a major inhibitory neurotransmitter. What that means is that when GABA reaches and binds to a specific receptor located on a neuron, it reduces the activity level of the neuron and makes it less likely to fire its action potential. Now, GABA is recognized by both ligand-gated and G protein-linked GABA receptors. In this lecture, we are going to focus on the ligand-gated GABA receptor called GABA A, as this is the main target of many anxiolytic and hypnotic agents. Now, the GABA A receptor is made up of 5 subunit proteins arranged to form a central pore. These subunits have been labeled with Greek letters such as alpha, beta, gamma, and delta. The subunit composition of GABA A receptors in the brain most frequently consists of 2 alpha subunits, 2 beta subunits, and 1 gamma or delta subunit. Furthermore, for each subunit, many other subtypes exist. The function of each GABA A receptor depends on which subunit it contains. For example, GABA A receptors containing alpha 1 subunit appear to be involved in sleep, while those that contain alpha 2 or alpha 3 appear to be involved in anxiety. Now, when 2 GABA molecules bind to the GABA A receptor, conformational change is induced, which results in opening of the central pore that allows negatively charged chloride ions to rush into the cell. This in turn increases the negative charge inside the postsynaptic cell, which makes it more difficult for an excitatory inputs to cause an action potential. Now, GABA A receptors are present in high concentration in the limbic system. One part of the limbic system is the amygdala, which contains many neurons that use the neurotransmitter GABA to control feelings of fear and anxiety. In times of stress, excitatory neurons in the amygdala fire rapidly, sending excitatory signals to other areas of the brain. It is this type of firing that leads to feeling of panic or fear. The inhibitory interneurons in the amygdala regulate these emotions by releasing GABA. The release of GABA and its binding to postsynaptic receptors such as GABA A inhibits the excitatory signals that result in feelings of anxiety and fear. GABA thus has a calming, tranquilizing effect on our emotions and prevents us from becoming overwhelmed in stressful situations. Now, in addition to a distinct binding site for the neurotransmitter GABA, the GABA A receptor has also a site at which anxiolytic and hypnotic drugs bind. These drugs can be divided into 3 groups, that is, benzodiazepines, barbiturates, and non-benzodiazepine hypnotics. Let's now discuss these one by one in detail, starting with benzodiazepines. So, benzodiazepines get their name from their chemical structure, which includes a benzene ring fused to a diazepine ring. Their binding site appears to be the region between the alpha and gamma subunit on the GABA A receptor. It's important to remember that benzodiazepines do not bind to the GABA recognition site located at the junction of the alpha and beta subunits, thereby they don't induce opening of the channel as directly as GABA. Instead, the binding of a benzodiazepine to its receptor site increases the affinity of GABA for the GABA binding site. This leads to increased frequency of the channel opening, and in turn increased influx of chloride ions at the postsynaptic cell, which ultimately makes it difficult for any excitatory inputs to cause an action potential. So when the excitatory signals caused by fear or stress are inhibited in this way, the result is decreased anxiety and greater feeling of calm. In addition to that, benzodiazepines can also produce mild muscle relaxation as a result of their action on GABA receptors in the spinal cord, cerebellum, and brainstem. The examples of benzodiazepines are alprazolam, chlordiazepoxide, clonazepam, diazepam, lorazepam, and temazepam. When it comes to side effects of benzodiazepines, the most common ones are related to their sedating and muscle relaxing action. They include drowsiness, dizziness, decreased alertness and concentration, as well as impairment of motor coordination. Now, let's move on to the next group, that is barbiturates. So, barbiturates bind to GABA A receptor at the alpha or beta subunit, which is different from the GABA binding site and also different from the benzodiazepine binding site. Now, just like benzodiazepines, barbiturates enhance the effect of GABA at the GABA A receptor. However, instead of increasing the ion channel opening frequency, they increase the ion channel opening duration. In other words, unlike benzodiazepines, barbiturates hold the ion channel open continuously for long periods of time. In addition to that, barbiturates can decrease the activity of excitatory neurotransmitters such as acetylcholine and glutamate, and at higher doses, they can also mimic GABA and directly activate GABA receptors, thus leading to profound central nervous system depression. This is why barbiturates have a much lower therapeutic index than benzodiazepines, meaning the toxic dose is not much higher than the therapeutic dose. The examples of barbiturates include pentobarbital, phenobarbital, and secobarbital. When it comes to side effects, barbiturates most often cause dizziness, lightheadedness, sedation, as well as memory and attention impairments. Furthermore, because of their narrow therapeutic index, it's important to remember that even small barbiturate overdose can result in coma or death due to respiratory depression. Now, let's move on to our last group of drugs, that is non-benzodiazepine hypnotics. As I mentioned at the beginning of this lecture, GABA A receptors in different areas of the central nervous system consist of various combinations of the subunits. The specific subunit that appears to mediate sedation is the alpha-1 isoform. So as their name suggests, non-benzodiazepine hypnotics are structurally different from the benzodiazepines, and as you may already guess, they selectively bind to the alpha-1 subunit of the GABA A receptor, thus triggering chloride channel opening with resulting membrane hyperpolarization. Because alpha-1 containing GABA A receptors are highly expressed in wake-promoting regions of the brain, the preferential binding of non-benzodiazepine hypnotics to these receptors results in sleepiness but not anti-anxiety effect. The examples of non-benzodiazepine hypnotics are zolpidem, Celepon, and ezopiclone. When it comes to side effects, non-benzodiazepine hypnotics can cause cognitive impairments, including memory loss, daytime sedation, as well as impairment of motor function. And with that, I wanted to thank you for watching. I hope you enjoyed this video, and as always, stay tuned for more.
Impaired motor function.